Yeah.
Do you know that if I want to buy medicine,
so please let's start. Let's start. And those of us that are having some funny background should mute. Everybody should mute. I'll mute you. Dr. Wamaka Uzonna, please introduce Omobowale. But before then, let me on this single honor. Really, my heart goes to those in Borno State, especially our colleagues who are living inside the sledgehammer of waters. This has been very terrible, challenging. We pray that they will come out, they will warm out to safety, and we pray that they will not be affected. Those areas that have been affected, we pray for them. Those that are dead, we pray for their souls, and we pray that no one will die again. And we pray that the water will recede, and we pray that the challenges which is being faced, that tomorrow that lessons are learned, so that there won't be a reoccurrence tomorrow. And the other areas in the country, and it's just going to be, I think, 3 or 4 states that will soon be under such sledgehammer. And our prayers and our advice is that things are being done to evacuate people on those premises, on those areas, because of the effect of disease generation and disease spread, wild animals in domestic environment, human beings submerged in houses, submerged in water, people moving about with canoes. Pray that emergency evacuation should be done in those areas, and proper things should be put in proper perspective so that we avoid a lethal reoccurrence. On that note, Amaka, please start.
Good morning, everyone, my elders, my colleagues, and most especially Professor Omobowale. You are all welcome to today's online meeting. So I will start with Professor Omobowale's profile. Professor Tayo Omobowale is a distinguished academic and researcher with over 29 years of experience in the field of veterinary medicine. Specializing in internal medicine, Prof. Omobowale has made significant contributions to the scientific community with a particular focus on advancing knowledge and practices in the case of domestic animals. With a prolific publication record, Professor Omobowale has authored more than 170 peer-reviewed articles in some of the most reputable scientific journals globally. This extensive body of work has earned him consistent recognition as one of the most cited Nigerian biomedical scientists, reflecting the far-reaching impact of his research. Prof. Omobowale's dedication to the advancement of veterinary medicine continues to inspire colleagues and students alike, solidifying his status as a leading figure in the field. In today's meeting, Prof. Omobowale will be taking us on a deep dive into canine ehrlichiosis, its clinical presentation in the field, and management so far. Prof. Sir, it's a warm welcome to you once again. Thank you for coming on board today. Our ears are all yours. Thank you.
Thank you, Dr. Amaka. I feel greatly honored to be here this morning. Dr. Ibe actually extended.
Your bandit is poor. Remove your
to me like 2 months. Hello, can you hear me?
Bandit. Yeah, your bandit is poor. Yes. Okay, continue.
Okay. Can you hear me now?
Yes.
Okay. So Dr. Ibe asked me to do this presentation about 2 months ago, but for some certain challenges, we had to postpone it till now. So I'm really excited that I'm able to do it today. Let me just share my screen.
Yeah, he's about to share his screen. Meanwhile,
okay.
Continue. Yes, good. Yeah, continue.
Okay, almost there.
Mm-hmm.
Just a minute, please, while I share my screen.
Good. Mm-hmm. Yeah. So he is about sharing his screen, and today will be a day in our life, in our history of veterinary
Okay.
doctor. Yes.
Can you see my screen?
Very well.
Okay. So I'll go right ahead, and in the next couple of minutes, I'll go through the lecture. I'll be talking this morning on canine ehrlichiosis, but I'll be concentrating along the line more on some manifestations that we don't really talk about in the Nigerian clinical space. Canine ehrlichiosis, as we all know, is a tick-borne disease which is caused by bacteria of the genus Ehrlichia. This disease was first discovered in Algeria in 1935, but its global significance became really very apparent during the Vietnam War. And it was because the Americans discovered that their dogs were dying, they were recording very high mortality rates. And they called it tropical canine pancytopenia. The condition was later identified as a severe form of canine ehrlichiosis caused by Ehrlichia canis. And since then, the disease has been well studied and various diagnostic and treatment strategies have been developed. However, despite the fact that the disease is has been known for close to 90 years, challenges still remain, especially in chronic cases where the infection can persist despite treatment. And this leads to very severe problems. The primary causative agent is Ehrlichia canis, and there are other species that can cause ehrlichiosis in dogs, like Ehrlichia ewingi and Ehrlichia schaffensis. These agents, these bacteria that cause ehrlichiosis, they primarily target white blood cells, and they live and reproduce within the membrane-bound vacuoles inside the cell. Unlike other gram-negative bacteria, Ehrlichia species do not produce endotoxins, but their intracellular location enables them to evade the host immune system. So this evasion of the host immune system is what makes them, what makes the infection to persist, and it can last for several months or even several years. Transmission is through the bite of infected ticks. And the brown dog tick, that's Rhipicephalus sanguinus, is the most common vector. In the picture you have here, this was a dog presented some years ago to the veterinary teaching hospital of the University of Ibadan. I hope I have the permission of my director, Professor Jeremiah, to share this picture. So this dog was presented. You can see the very heavy tick infestation. When somebody saw this, somebody requested for the picture of a dog with ticks. And the person jokingly replied that they asked for a dog with ticks, not ticks with a dog, because the infestation is so heavy. So the bacteria are found in the tick salivary glands and are transmitted to the host during the blood meal. And once the tick attaches to the dog, the blood enters, the bacteria enter the bloodstream, they invade the white blood cells, and from the bite of an infected tick transparently by blood transfusion. And that's the reason why we always advise colleagues that before you transfuse blood, make sure you screen the blood to check for parasites. Blood transfusion is another way in which the disease can be transmitted. Now, following the transmission by an infected tick, the Ehrlichia organisms enter the host's bloodstream and they quickly target and invade leukocytes. And the bacteria persist intracellularly within the membrane-bound vacuoles in the cells. And this is what shields the organism from the immune response and makes them more resistant to certain antibiotics. And the figure you have here is an electron microscopy illustration of Ehrlichia in an infected cell. Now, the parasite has a way of evading the immune system. For example, Ehrlichia uses surface proteins such as Ehrlichia transmembrane protein to adhere to host cells to initiate infection. And this promotes the uptake of the bacteria into the cell, and it facilitates survival. And also, apoptosis, which is a defense mechanism to destroy infected cells, is manipulated by Ehrlichia. Ehrlichia inhibits programmed cell death, that is apoptosis, through various proteins, and it allows the bacteria to evade immune response. We also know about oxidative stress, that oxidative stress is another mechanism by which the system protects the cells from damaged cells or from infected cells. You know, there has to be a balance between oxidants and antioxidants. What Ehrlichia does is to prevent the production of reactive oxygen species. With the prevention of reactive oxygen species, this interferes with the host's cytokine signaling pathways, such as the Janus kinase signal transducers and activators of transcription, and this prevents immune system activation. And also, the organism manipulates the host cell signaling. And these are mechanisms by which the organism is able to evade the host immune system. Now, when the organism is well established in the host, there are a number of clinical phases that the disease goes through. We can identify 3 clinical phases: the acute, the subclinical, and the chronic. The severity of the disease depends on factors such as the strain of the Ehrlichia, the host status, and timing of diagnosis and treatment. So when we talk about these clinical phases, each clinical phase presents different clinical signs, and the severity of the disease depends on factors which I've mentioned before: the strain of the Ehrlichia, the immune status of the host, and the time of diagnosis. Why do we talk about the time of diagnosis? In some situations, in some clinical scenario, the patient might not be presented until the condition is well advanced. And it could be due to the fact that the clinician is not able to diagnose the disease promptly. The acute phase of the infection, which takes place about 1 to 3 weeks post-bite, there are a couple of clinical signs that can be seen, like fever, like lethargy, loss of appetite. There can also be generalized lymphadenopathy, enlarged lymph nodes. There can be splenomegaly, and there can also be petechial and ecchymotic hemorrhages. Epistaxis can be found, and hematological evaluation can show thrombocytopenia. In some dogs, especially those with weak lines, can develop, which include neurological symptoms, ocular manifestations, cardiovascular manifestations as well. In the subclinical phase, the disease is often asymptomatic. This phase follows the acute phase and can last for months or even years. Dogs in this phase may appear outwardly healthy. They may not show any obvious signs of illness. However, the infection persists in their body. And thrombocytopenia can be seen in them, but it can be mild. Despite the absence of clinical signs, the bacteria can cause low-grade chronic infection. And if this is left untreated, the subclinical phase can progress to the more serious chronic phase. In the chronic phase, signs like weight loss, persistent fever, very severe anemia, which is often non-regenerative, can be found. Then bleeding tendencies such as epistaxis, hematuria, melena can be seen. And there can be generalized lymphadenopathy, splenomegaly, and hepatomegaly. In this phase, neurological signs, which can include seizures, ataxia, vestibular dysfunction, can be seen. Ocular manifestations can be seen, as well as cardiovascular manifestation. Now, at this phase, the clinical signs observed are such that they mimic several other conditions. Laboratory findings in this chronic phase include pancytopenia, hyperglobulinemia, hypoalbuminemia, and proteinuria. And these, the pancytopenia is due to the fact that the bone marrow has been suppressed. Hyperglobulinemia because of the chronic immune response. Hypoalbuminemia because of the bleeding. By the time the animal bleeds into the GIT, which is manifested as melena, epistaxis, and so on, there can be hypoalbuminemia. And in addition to that, the hepatic involvement can also cause hypoalbuminemia. Proteinuria, which can result, which can be an indication of glomerulonephritis, can also be found. So I'll be talking now about some of the severe manifestations, Ehrlichioses. And these manifestations can mimic several other infections, several other disease conditions. So I'll be talking about the neurological manifestations, cardiovascular manifestations, and ophthalmological manifestations. Some dogs, particularly those with more severe infections, may develop these neurological symptoms, such as ataxia. The animal is presented, and the major presentation is lack of coordination. There can be hyperesthesia, in which case the animal reacts excessively to touch. There can be muscle deficits, and there can be seizures. And these symptoms result from the invasion of the central nervous system by immune-mediated responses, leading to meningoencephalitis. I found one publication in which the authors reported a case of Ehrlichioses with neurological complication, and they were able to detect the organism in the CSF, in the cerebrospinal fluid. As clinicians, we should consider complications of Ehrlichioses. Also, neurological complication in Ehrlichioses can manifest as paresis. That's weakness of the limbs. It can also manifest as vestibular signs, which the animal shows signs of imbalance. Also, ophthalmological complications. This can lead to blindness. Cardiovascular complications. This can manifest as various degrees of anemia, of action. We have seen situations in our own practice in which dogs with Ehrlichioses presented with very severe hypotension. It is usually it usually presents with bad prognosis. Okay, now myocardial injury has also been reported in the findings of elevated cardiac troponin levels, which indicate myocardial injury. And this has been found in other infections like Babesia. This is that myocardial injury is likely due to a combination of factors such as myocardial hemorrhages, myocarditis, vasculitis, and a systemic inflammatory response. There was a study conducted in 2019 by Gianfrancesco Filippi and others, and they looked at ECG findings. They wanted to evaluate the presence of arrhythmias and abnormal electrocardiographic findings in Ehrlichioses. And what they found was that 45% of infected dogs presented with arrhythmias. And the arrhythmias included first and second degree atrioventricular block, ventricular and supraventricular ectopic events, and sinus tachycardia. All these complications, they have impact on the, especially in a country like Nigeria. When a dog is presented to you with Ehrlichioses, you are able to diagnose it, you treat. You also have to consider the organ complications that might have resulted as a result of that infection. For example, if an animal is presented and it is having ventricular arrhythmias, that could result in very, very poor prognosis. Unfortunately, many people cannot investigate that because of non-availability of the right equipment to use. And also in that study, they discovered that one dog had over 7,000 ectopic events with sustained ventricular tachycardia. Ventricular tachycardia is usually a sign of poor prognosis. It's a sign of poor prognosis. So despite the fact that you have been able to detect the organism and you have placed on treatment, management of these arrhythmias would be a very good step to ensure survival of the animal. And also they found P and R wave abnormalities, which were reduced in infected dogs. Increased T wave amplitude was found in 50% of the infected dogs, and they attributed these changes to myocardial injury or fluid imbalance. There are so many things that can cause these abnormal changes found. And also, higher frequency of arrhythmias in infected dogs was found compared to the controls. However, in that study, they found that despite arrhythmias, there was no clear association with survival outcomes. So sometimes there could be electrocardiographic abnormalities and the animal will still survive and the animal could die. They could not really get any association. But the take-home message from that study is this: routine ECG monitoring is crucial for detecting these arrhythmias in dogs with ehrlichiosis, and early detection of arrhythmias could help improve management and clinical outcomes. Because some of the findings from the ECG, especially with the T wave amplitude and with the T wave amplitude, they suggest myocardial stress. Another manifestation which many people don't tend to look out for is the ocular manifestation. Ocular manifestations are common in infected dogs. And it is very important to diagnose it early and to treat early, because if not treated early, this can lead to blindness. And it's going to negatively impact the quality of life of the patient. These are the usual signs seen: anterior uveitis, that's the most common, panuveitis, retinal detachment, optic neuritis, and ocular bleeding. These are the most common signs, ocular signs associated with ehrlichiosis. There were two studies conducted, one by Leva et al. And another one by Comenio et al. The study by Leva et al. Found, while the one by Comenio et al. Found ocular involvement in 100% of dogs. And this ocular problems are believed to be due to immune-mediated inflammation. Like I mentioned earlier on, early detection of ocular signs is very key to preventing blindness, as endemic areas like ours presenting with ocular issues. We tend to attribute some of the ocular problems we see in this part of the world to trips or to infectious canine hepatitis, but rarely do veterinarians think of ehrlichiosis. These are some pictures of ocular manifestation of canine ehrlichiosis. For example, in this picture, you can see chronic unilateral anterior uveitis in a dog with canine ehrlichiosis. Notice the sclera and conjunctival congestion. I'm trying to activate my pointer. Look at the congestion. And also, when you look at this part of the eye, you will see that the animal is also having some cataracts. In this one, there is very severe keratouveitis in a dog with ehrlichiosis. Very, very severe. You can also see the mucopurulent discharge here. In this one, you can see scleritis and the conjunctival congestion. And also, you can see subconjunctival prolapse of the uveal tract. You can see the prolapse around here. In this next one, there is orbital cellulitis. There's cellulitis. And notice the severe periocular swelling and profound hemorrhagic crusting. You can see the hemorrhage around here. And all these are due to ehrlichiosis. You know, in a case like this, because of the appearance, the manifestation of this ocular lesion, one could be tempted to think this is a case of snake attack, venomous animal attack, because of the ocular swelling and the ocular cellulitis that can be seen. This one was presented to our VTH some time ago, and is a dog that was presented with ehrlichiosis, and you can see the corneal edema. You can see the cornea appearing bluish, and also you can see the lacrimation. You can see the lacrimation. I want to see if I can, yeah, this is the dog. Severe ocular manifestation, blind. Here, you can see
Prof, sir, we can no longer hear you.
Hemorrhage. There's retinal. Hello?
Yeah,
Can
yeah,
you
we're
hear me?
hearing you now.
Yes. Okay.
You are hearing me now?
Yes.
Okay, let me go. Did you hear when I was explaining this?
Yeah, continue. No, continue.
Okay.
There's a periocular hemorrhage. There's periocular hemorrhage there.
Yes. So you can see the conjunctival hyperemia and hemorrhages. So treatment for ehrlichia, doxycycline is the first line of treatment, and it induces clinical remission, but it does not always eradicate the infection. When you're treating with doxycycline, you treat for 3 to 4 weeks. Sometimes when we tell clients that the animal has to be treated for a month, we sometimes get alarmed that a whole month. In a VTH, in our veterinary teaching hospital in UI, we always like to start with oxytetracycline, then we follow up with doxycycline. And we always advise the clients on compliance. They have to comply. They have to comply. Another very good tetracycline is minocycline. Minocycline. I've never seen minocycline in Nigeria before. If anybody has, maybe they can tell us on this call. Minocycline also works very well, and its effect is similar to what you see in doxycycline. Rifampicin used to be used. It is an alternative to doxycycline, and it's used for 3 weeks. Imidocarb dipropionate, a recent study has shown that it is not so effective, and it is not recommended to be used anymore. Enrofloxacin sometimes is combined with doxycycline. And to give a better effect. Drugs like chloramphenicol and azithromycin have been tested, but they've been found not to be so effective, and they are not recommended for use. Probably some research can be done to see whatever the effect of their combinations with other drugs will be. Now, apart from treating with antibiotics, especially doxycycline, which works very well for the infection, symptomatic treatment is very, very important. For example, in an animal that has already developed severe anemia because of bone marrow suppression, blood transfusion is very, very important. Blood transfusion is very, very important. And supportive care, which might include using the use of analgesics, fluid therapy, blood transfusion, blood component therapy, as the case may be, it is very, very important in some cases to ensure that the animal survives. Now, even though the disease in the chronic phase is known to cause bone marrow suppression, the use of corticosteroids can also be considered. And this is to manage immune-mediated complications. Okay? Whenever these corticosteroids are to be used, the clinician has to weigh the pros and the cons before using it. Their use should always be carefully considered so that immunosuppression would not be exacerbated. Prevention, like we know, is by tick control. Very effective tick control is crucial in preventing ehrlichiosis, and the regular use of tick preventatives is recommended. I know Dr. Ibe gave me some tablets some years ago. I don't know if he still markets it. Maybe he will tell us after the lecture. So, as veterinarians, we should always advise our clients on tick control. They should monitor their dogs regularly for ticks. They should check their compound for ticks, because this is the only way to prevent this disease. And also, when we educate them that although dogs cannot directly transmit Ehrlichia to humans, there is evidence to show that infected ticks can bite both dogs and humans and can lead to human ehrlichiosis. So we should always endeavor to educate our clients on this. In conclusion, ehrlichiosis is a very complex disease. Apart from just invading the white blood cells, it can also have profound organ involvement, organ complications. Early diagnosis and prompt treatment are very, very critical, especially for the ocular manifestation. Recognition of the ocular signs and proper management, very important, so that there won't be there won't be blindness. Sometimes when you treat the infection, the ocular manifestation also disappears. But sometimes, depending on when the animal is presented to you as a veterinarian, you may also need to intervene by applying specific ophthalmic treatment to treat the ophthalmic complications. So the infection also can lead to very severe organ complications, which can negatively impact the outcome, the clinical outcome. Okay. Thank you very much. I'll be open for questions and comments.
Yeah. Yeah. Dr. Wamaka, are you still there?
I am here, sir.
Okay,
yes.
You're here. So you can tidy up what she's saying and maybe add one or two things on ticks. Then ask your questions and other people will flow with you.
Okay, thank you, Prof. This was a very, very informative and enlightening session. Yes, of course, canine ehrlichiosis is transmitted by Rhipicephalus sanguineus, and they are very ubiquitous in the environment. And I appreciate your input and the emphasis that you laid in the treatment and in the prevention of ticks as one of the major ways to curb the spread and to manage this disease. I followed you. You rightly said the use of acaricides should be encouraged among pet owners. And currently, I think it's being encouraged to use the Bravecto and Simparica tablets in the control of tick infestations in the animals, in our dogs. And from what pet owners have said, it has proven to be a very, very efficacious method of tick control. But I think the problem still remains the cost of these acaricide. It is not really affordable to everyone, most of the pet owners, and most of them don't appreciate the use of a lot of money to buy these tablets to treat their dogs. And so I think it's a major constraint or challenge to the prevention of this disease. And then again, I would say that canine ehrlichiosis is kind of a silent killer, because like what most clinicians and what pet owners are conversant with is canine trypanosomosis. And canine trypanosomosis also has this ocular involvement in its manifestation. And I believe that is also why canine ehrlichiosis is missed out most times in diagnosis, also giving also the challenge that we have in diagnosing canine ehrlichiosis. So my question is this: what do you say about the incorporation of rapid test kits? I know there are rapid test kits that you could use to diagnose this canine ehrlichiosis in order to aid fast or prompt control and management of this disease.
Yeah, thank you very much. Yeah, in the diagnosis of canine ehrlichiosis, rapid test kits are very, very important, and they are they are available. I missed out that slide. Let me quickly share that right now. They are commonly available, and usually they come in. I'm trying to share my screen to show you one there. Okay, like this rapid test kits, they usually come such that they can detect several organisms at the same time. For example, you have kits that can pick Ehrlichia canis, Ehrlichia ewingi, Anaplasma, Lyme disease, and so on. So these are very, very important. And apart from that, hematological cytology to pick the organism in the white blood cell is also very, very important. By far, the most effective, however, very expensive, is PCR. Because there have been reports in which the rapid test kit did not pick the organism, cytology did not pick the organism, but the organism was only picked by PCR. In Nigeria, I think we've had two publications. I've seen two publications on the use of PCR on Ehrlichia, one by Kamani, I think in 2018 or thereabout, then another one from FUNAB. So I saw those two publications. The only problem with PCR, which is the best of all the tests, is it is very, very expensive, and you need a specialized lab to be able to do it. And there are so many equipments involved. But for the teaching hospitals where some of these equipments are, if they can invest in such diagnostic tests, PCR, that's molecular detection, that makes it very good. But when it is not available, the rapid diagnostic kits like we have here and cytology can also be, they can be employed to ensure that diagnosis is done as soon as possible.
Yeah. Thank you. Mwamaka, continue.
All right, thank you, Prof. Please, what would you say is the most common manifestation of this of ehrlichiosis out in the field for field veterinarians? What would you say that don't have access to these rapid test kits, knowing the challenges we have with veterinary practice in Nigeria? What would you say is the most common manifestation? What would you look out for, or what would you advise or recommend that they look out for?
Okay, thank you very much. Now, the problem with ehrlichiosis is that the clinical signs are not specific. What you find in ehrlichiosis, you can find in so many other conditions. The bleeding tendencies that you see in ehrlichiosis because of the thrombocytopenia, you can also find it in babesiosis, you can find it in leptospirosis, you can find it in poisoning. So one cannot rely on that. The ocular manifestation you can find in other conditions, but by far, most people begin to suspect ehrlichiosis when they see bleeding tendencies, increased clotting time. For example, when an animal is presented with epistaxis, then many veterinarians begin to suspect ehrlichiosis. But by far, there are so many other non-specific clinical manifestations that can be associated and that are associated with ehrlichiosis. And this is what I would rather advise my colleagues on the field. When you have an animal that has had a history of tick infestation, as much as possible, try and get the blood sample to a lab to check for the organism in the white blood cell. Even if they do not find it, you can preemptively treat for ehrlichiosis, especially when you are beginning to see some of the clinical signs associated. For example, epistaxis. So you can preemptively treat. But like I said, most people begin to suspect ehrlichiosis when there are bleeding tendencies, like epistaxis, melena, and so on. But ehrlichiosis can be in an animal that has not yet advanced to that level.
Yeah. Amaka, do you get Dr. Funke Adebayo's question? Can you ask him?
Yes, yes.
Yes.
Dr. Nasri is raising his hand.
Then before
so
then, we'll ask Nasir. No, let him take Funke Adebayo's question. And then after that, Nasir will speak, and then we'll come back.
Okay, Prof. Dr. Adebayo said, thank you so much for our dear Prof. My question is about the hardy nature of canine ehrlichiosis, which thrives in the body organs and surfaces, especially in immunosuppressed animals. We treated a case like that. The pet recovered, but got pregnant and eventually died of the same infection after whelping. How can we combat this chronic nature? Thank you, sir.
Thank you very much for that question. One question I would have loved to ask, if the animal was presented to me, was, were you able to ascertain that you actually cleared the infection from the animal? Because you treated for how long? What was the duration of treatment? For how long was the animal treated? After the treatment, did you take samples again? Did you go to the level of molecular screening to ensure that you actually cleared the infection from the blood? These are things you need to ask yourself. Then another thing is, did you assess the animal for organ complications, severe organ complications following ehrlichiosis? You know, in this lecture, we talked about cardiovascular complications. Okay, did you actually evaluate the animal for such complications that can lead to very poor outcomes afterwards? So these are some of the things that one has to consider. So when your question says that, how can we combat this chronic nature? When the animal is presented to you in the chronic phase, of course, you know that there can be very severe organ complications. After we have treated the organism, you also have to monitor the organs to be sure that the organ complication has been reversed. One thing we know about some of these infectious diseases is that sometimes after you clear the organism from the system, the effect of the disease on the organs still persists. Let me give you an example. You have an animal presented to you with ehrlichiosis, and the animal already has retinal detachments and hemorrhages. After you clear the organism from the system, I'm sure the animal will never see again, because your doxycycline and anything you use will not reverse that retinal detachment. So I wouldn't know what complications the animal presented with at that chronic phase, which probably would have required further management, apart from the specific treatment for ehrlichiosis. And this applies to so many other infectious diseases too. Thank you.
Thank you. Nasir will speak. Now, I don't know about ehrlichiosis, but I know much about trypanosomiasis, that the blood-brain barrier, most drugs don't cross it. And those those organisms go to hide beyond the blood-brain barrier. That's the choroid plexus. So once you clear the ones in the system, there's bound to be reinfection. So I don't know much about ehrlichiosis on that. So that's it.
Let me quickly say something about trypanosomosis because you mentioned it. In a condition caused by Trypanosoma brucei, for instance, even if you don't have complications in the nervous system, there is something we have found in Ibadan, that when dogs are presented with trypanosomosis, and we evaluate them and we see a particular pattern on the electrocardiogram, even when we clear the infection, the heart never recovers. Once we see that particular pattern, once we see supraventricular tachycardia in an animal, in a dog with trypanosomosis, there is no amount of treatment you give. The animal will still succumb. And what we now do is, when we have such cases, we evaluate, we do our electrocardiogram, and we see that manifestation, we advise the client on the possible outcome. So sometimes animals dying after you treat them, and you treat them successfully, you treat the causative organism, the problem is due to the organ complications, which the specific treatment for the organism might not necessarily take care of. Thank you.
Yeah. And I don't think such a animal supposed to be subjected to a higher physiological phase like pregnancy. It's not the best. Anyway, Nasir, please, can you open up? Your hands have been up. Thank God it's electronic hand. Yes.
Yes, thank you, Dr. Ibe. And let me say, I'm quite happy about this lecture this morning. Yes, I didn't join quite early because of some emergencies in the hospital. I joined when it was about talking about the ocular manifestation. And the thing is, when you have a 360-degree kind of lecture like this, it leaves you with greater satisfaction, because you don't even know what question to ask, because the lecturer has dealt with all aspects of the topic itself. So I want to congratulate Professor Omobowale for that very resounding reminder that he has given us this morning. But in just 1 minute, let me just share my experience, because I got so much enthralled with the ocular manifestation thing. And because it has cost me and my Oga here, I'm sure it's on call, Dr. Abiade, a little embarrassment over some 30 years ago. That was the first time I ever came in contact with the name doxycycline. All we knew then was oxytetracycline. It was a dog that eventually got blind under our supervision, because we did not recognize the fact that it was having ehrlichiosis. At that time, diagnostic tools were very limited. We just knew that we're having a dog with fever, was not eating and all that, and we kept pumping oxytetracycline until this dog was eventually flown to France. It was owned by the then manager of Sheraton Hotels in Ikeja, and it was from France that we were written that, well, we were dealing with ehrlichiosis and we should have started doxycycline instead of oxytetracycline. I think eventually the dog got blind. This was 31 years ago or thereabout. At that time, diagnostic tools were not this around, and that was my first encounter with ehrlichiosis in its real sense, and how it can cause a lot of problems for people and dogs and all that. So we soaked in that embarrassment, and since then we have improved to the glory of God. And then I'm saying this so that people can know, because there could be people who are still, even though they are being drowned in all the possibilities, all the things that are available for diagnosis now, but they are not availing themselves with such tools and all that. so that you won't get embarrassed like we did about 31, 32 years ago, and that you should just make sure that you do your diagnostics very well. But I would like to talk to Prof concerning what we see in the clinic on a daily basis in terms of when these cases are presented. Because sometimes, you know, the behavior of the average owner in Nigeria is they don't come until it is almost bad, completely bad. And by the time you see it, perhaps you are seeing, you do serum biochemistry, you are seeing renal signs, you are seeing you are looking at the dog, you are seeing polyarthritis, you are seeing neurological signs, you are seeing so many signs. And at that time, a lot would have happened. So when they present some of these cases very late, just like Prof said a few minutes ago, the damage would have been done. And even if you clear the parasite, you are not able to clear the complication that has damaged the body of the patient, so to say. So we still see that a lot of times, and then they are saying that, oh, you are not able to treat because they didn't know that they had caused the problem from happening in the first instance. And that brings me to the last point that I wanted to make this morning about our ability to assess very credible labs in terms of the hematological presentations of this disease. You know, when you see, sometimes you see pancytopenia, leukemia-like appearance, you know, so many things, cyclic thrombocytopenia, so many other things that you see, and it's almost very difficult to now say, oh, it is this. But thank God the rapid test kits are there, but sometimes they are not reliable. We get false negatives, false positives sometimes. So it becomes a conundrum. And the only thing we do, and we think is effective, is using doxycycline for, as Prof has said it, 28 days minimum. Even though we see have resistance from clients, sometimes I'm torn between, can I house this dog for the 28 days, or do I trust this owner to give the drugs? And most of the time they don't. So you see the infection record. Maybe they've done it for their 14 days and they see some apparent improvement and they just leave the dogs and they are left with the remaining regimen in their hands. So it's a problem. So Prof, what is your recommendation, or what is being done at Ibadan? Do you keep these dogs for 28 days, or do you at any point in time rely on the clients to comply with your instruction? And after you think they have complied with it, do you have any feedback from them in terms of maybe you want to retest or something? Because I still have that as a problem, because they are not able to pay my boarding fees for a month because of the medication, and at the same time I'm not able to trust them, you know, to give it for 4 weeks. So what do you do in Ibadan, sir?
Yeah, thank you. Thank you very much. Thank you very much, sir. In Ibadan, we rarely treat Ehrlichioses, cases of Ehrlichioses as inpatients. We treat them as outpatients, and we always advise them. They have to comply. Compliance is very, very important in this case. I think sometime in 2004, 2005, we had a client, a very good dog lover. The man, there was a time he was attacked. His house was attacked. He was shot. His dogs were also shot. But the dog that was shot was the one that actually saved him at the end of the day. You won't believe that the man brought the dog to the clinic for treatment before he took himself to the hospital for treatment. So there was a time this man's dog had Ehrlichioses. We were able to diagnose it. And we told him that the treatment will be for 4 weeks, for 1 month. And the man was coming every day, all the way from Ijebu-Ode. Mr. Ajayi, I've not seen him in quite a while now. He was coming every day. He would drive all the way from Ijebu-Ode to Ibadan just to receive the treatment and go back. He did not want to take the drugs. He just wanted us to treat, monitor. That was what he was doing every day. Some clients are that dedicated. And of course, just like humans, we humans, there are some clients, once they see a little bit of improvement, that is the end. They don't come again. they don't come again. But really, the best thing would have been to ensure that the dogs are treated for the full number of days, receive the full course of treatment, and evaluation is supposed to be done again after the treatment is complete. But like you rightly mentioned, sir, there are so many clients who don't want to pay your bills. They don't want to pay for the kits. They don't want to pay for anything. So they just tell you that the animal is okay, the animal is eating, is playing, and they leave. There is little we can do about that. We can't force them.
Yeah, I think Dr. Amaka has told me she will soon sign off, so maybe I'll take over. Abiade will let Abiade discuss, then we'll go to the chat box to pick up the relevant questions. So, Dr. Abiade, please.
Hello, the moderators and Prof. Thank you for this beautiful. Are you hearing me?
Yes,
Thank
sir.
you for this beautiful lecture. I mean, as Dr. Tunji said, it's a 360 degree. You try to cover almost every aspect. I just have one or two questions, maybe a comment. One, in a situation that, because this is a scenario that happened in Lagos, the scenario that the dog was presented, and then the primary vet felt that, oh, this is a case of Ehrlichioses, and then also knew that from the laboratory investigation done, that the dog was also having a renal asthenia. Okay, and then this same dog was placed on a 28-day course of oxycycline, doxycycline, and then after then it was reevaluated, and this same dog was still having renal asthenia. I mean, renal injury, and then eventually the dog died. But the primary vet, what do you think? What do you think should have been done in such a situation? Okay. Hope you got my question.
Okay.
Okay. Then the second thing is that you have said it, because in some cases on laboratory investigation, you do your white blood check count, and the liquor is not found because it has been treated for some time. Does that invalidate the result? Does it invalidate it? Well, because there was a case like that after the treatment was done for 28 days and then it was not found. Another clinic said, oh, the result must be fake because the liquor was not found. Is it compulsory it should be found? Thank you very much.
Thank you very much, sir.
I hope you're able to get my two questions.
Yes. Whichever one I forget, I will ask you again. The first one you presented, the animal was, I think the animal was referred. It was attended to by someone. It had Ehrlichioses, and it also had renal disease.
Yeah.
Am I right, sir?
Yes.
Okay. I guess the dog was referred to you.
No, not referred to me. Referred to another clinic.
Okay. Aha. Now,
because it became a problem between two veterinary facilities. Who was to be blamed? Who did the wrong? Who did the right?
That is one thing that we see a lot in our kind of practice.
Yes.
Being a referral practice. Because sometimes when cases are presented, they're either presented very late and very bad, or very well messed up. I think what the veterinarian that received the dog,
The primary.
what is the secondary
Yes.
veterinarian. What he should have done was that he should have done a full evaluation of the animal. Hematology, serum chemistry, taking very good history. And he should have tried to ask questions about to ascertain the probable onset of the renal disease that the animal was presented with. Because the fact that an animal is presented with ehrlichiosis and it also has renal disease and it also has a cardiovascular disease and all forms of, all other comorbidities, does not mean that everything was caused by that ehrlichiosis. The renal problem might have been there for long.
Yep.
And I think I'll blame the secondary veterinarian because...
No, just a minute. I think okay. you didn't get it right.
Okay.
My first question is that the primary vet realized that this dog was having all this comorbidity, but was concentrating on ehrlichiosis, and he treated for ehrlichiosis for 28 days.
Okay.
Before the client went to another client, and the secondary now refused to treat because he said, this is happening and I cannot do this. But the first was trying to wriggle itself out. So my question is that if you know that this dog is having all this comorbidity, what will you do concerning your ehrlichiosis treatment? Will you be more careful in the use of some drugs or not?
Okay, thank you very much, sir. Yes, I get the question very, very right now. Now, in renal failure patients, we use doxycycline, but we don't use oxytetracycline. So the use of doxycycline in that renal failure patient is okay. But the thing is this: the primary veterinarian who was treating just ehrlichiosis without doing anything about the renal disease,
monitoring it
very well. I hope you understand what I'm trying to say, sir. Yeah. And I can't blame the secondary veterinarian who saw the animal already in renal failure, because my experience with the kind of clients we have in this part of the world, not only veterinarians, even in human practice, it is where the animal dies that all the blame is heaped. So the secondary veterinarian, trying to be very, very careful, I wouldn't blame the person too much. Even in human practice, I've seen situations in which very bad, 4th degree metastasis of breast cancer, to the lungs and everything is presented to the teaching hospital. And when the patient dies, the relatives begin to blame the doctor in that hospital. Yep. So I wouldn't blame the secondary veterinarian for being careful. But my advice to my colleagues generally as veterinarians is, let us know and perfect the art and the act of clinical evaluation. Yeah. If the primary veterinarian had told the client that your dog has ehrlichiosis, but as well, it has renal failure, I think the client would understand that, okay, we will try and treat this ehrlichiosis, then we will try and see what could have been responsible for this renal disease, and we will see if we can manage it or not. But the client would have been given a prognosis, would have been given a likely outcome. So, as veterinarians, we should examine very well. And as well, we should inform our clients. Client education is very, very important. Very, very important. Or else, when their animals die, for reasons due to their negligence, they will still blame us. So, sincerely, sir, I wouldn't blame the secondary veterinarian for being smart.
Okay. I mean, thank you very much. I mean, what we're just trying to point out is that, I mean, when you said, 28 days, we should put a caveat there. We should not just say, 28 days, and then the patient is on this particular job. It needed to be monitored. We need to monitor it so that we will not end up on some unnecessary complication that happen. Unfortunately, the primary vet heaped the whole blame on the secondary vet, and it was a messy affair. It was so unfair, but that is what it did. They embarrassed the secondary vet. I believe both of them are on this call, so that's why I want it to be well clear.
Yeah,
I mean, both of them are on this call. I could see them. So monitoring of your treatment plan is so important. In fact, the client just went to the secondary vet that we should just increase the number of the drugs. We should just found that one. Where we should not just treat and just leave the client to just do whatever it is. We should continue to monitor. When you are treating ehrlichiosis in view of the multi-organ failure, we should not just do it as a fait accompli and assume that after so days it will. You need to monitor such a case on a weekly basis so that you know what is going on. Thank you very much for a wonderful.
Thank you. I think we are building a topic for the future, and that's veterinary ethics. And our resource persons are here: Dr. Nasir, Dr. Abiade, and Professor Omobowale. Three of you will call you one day to discuss veterinary ethics, more especially in small animal medicine. Maybe we'll bring other people in other areas. So why we're here actually is for us to enrich our practice without any hula baloo or interworks of some blames. It's not fair on us as a component. We should operate and practice as a unit. And be it as it is made, as we are practicing as a unit, we should work under ethics. I don't know how far this ethics is taught these days. Even during our own time, it was not well taught in public health or something close like that, epidemiology or something like that, or sorry, under jurisprudence. So, but I think we'll be an enabler. You have built up a topic, and please, any day we invite three of you, Dr. Tunji Nasir, Dr. Abiade, and Professor Omobowale, please up yourself, the handshake. Don't put your hands behind your back when we give you that handshake. And then Amaka, is she here? If she's not here, then we'll go to other questions. Professor Omobowale, asked one question or some about epistaxis, which normally is what we see in the north when I started practicing, and it didn't go to these hydra heads. Once we get epistaxis, and you know, because of the limited frame we found ourselves, then we have a very good tetracycline erythromycin, which is the best I have ever come across. And that's what we use, and the thing will remiss. But anyway, she's talking about epistaxis. How do you control epistaxis? I don't know whether you mentioned much about it in your discussion. Thank you.
No, I did not talk much about it. Yes, I can see Professor Ukamaka's comments. She actually talked about a study they did, which is very, very true. Cytology did not reveal so much, but the rapid test, they got more than 40% using the test kit. So with Ehrlichia diagnosis, like I mentioned, PCR is the best, is the gold standard. It will pick it will pick the infection, even when the rapid test cannot, when cytology cannot. So thank you for that. Thank you for that comment. But the thing is, by far, most people rely on detection of the morula in the white blood cells, but that fails several times. Okay, now for the treatment of epistaxis, when epistaxis is observed, the first thing to do is to keep the animal calm, keep the animal very calm. Then you can ensure that the bleeding episodes don't increase. Although when you see epistaxis, that does not mean that it is, confirmed that ehrlichiosis is the problem. There are several other causes. But keep the animal calm. Position the head such that the head is elevated. And you can also apply a cold compress. Apply a cold compress, and that will help constrict blood vessels. But so many times we use, in addition to all this, we use topical vasoconstrictive agents like adrenaline. Just instill adrenaline into the nostrils, and this can help to stop the epistaxis. But one advice I always like to give the clients is this: when they get back home, they should make sure they don't get the animal excited in any way. They should get their cold pack, their cold compress ready all the time, because I don't advise them to administer topical adrenaline. The cold compress, keeping the animal, calm. Those are the things I advise for their home care. But in the clinic, I add adrenaline. That is what I do.
Yeah. Thank you very much. And then somebody asked, Amarachukwu asked, after treating with rifampicin and the doxycycline, they found out that it comes back again. So what must have been the cause? That is, after treatment, they will go. It will come back again.
In the in one of the slides I shared, it was discovered that drugs like rifampicin, azithromycin, we are not effective. So that takes us back to doxycycline. Now, if you use doxycycline or any of the drugs that are known to be effective and there is relapse, well, there are questions to be asked. Did the client comply? What was the compliance? Was the compliance very good? Another thing is, what was the duration of treatment? So, but talking about rifampicin had been tried and found not to be so effective.
Yeah, thank you. Awuduoko is asking one good question. Based on limitation of area of his practice, which is okay, because we have limited areas of practice in the field where most of these facilities are not within reach, and is asking, how possible is it for a private veterinarian to carry out blood transfusion in dogs, vis-a-vis the complex nature of blood group of dogs? Dr. Awuduoko, Pig Vet, Abuja. When it comes that you transfuse blood, how is it possible? And how do you measure the blood groups, the matching or matchable blood groups? I'm not in pet practice per se, so I think I've lost some touch. So what is the, based on the challenges being presented, how do you outclass the challenges?
Sorry, I missed. I went offline a bit. Can you repeat the question, sir?
I say, based on the limited facilities in the field, in terms of blood transfusion, for those in private practice, in areas you don't have all these diagnostic tools and monitor tools, how do you how do you carry out blood transfusion in dogs vis-a-vis the complex nature of the blood group of dogs?
Blood transfusion is another is a topic. I don't even know where to start from. Where to start about talking about blood transfusion now. But let me just say this.
No, we will bring out a time to discuss blood transfusion actually, but just in a jiffy. Because you see, what we do is that as we progress, we generate topics. So we don't build these topics from out of any our own volition. We build it as it emerges. Like now, 2 topics are coming out. But Ukamakez, I think, Prof wants to speak. But when we finish, maybe she will add her pep tune to what we're saying.
Okay. Now let me quickly talk about blood transfusion. We had a conference recently, Savant conference, and a session was dedicated to blood transfusion, including practicals and what we can do on the field. Now, if you are in a place where there are not so many facilities and you want to do blood transfusion, well, there are some things you must get. For example, you must get the blood collection bag. That is very, very important because you cannot collect blood in a syringe and and transfuse like that. You must get the blood collection bag. You must have access to a lab, at least to get the PCV of your donor and the PCV of the recipient. And you must be able to screen the donor for blood parasites. Okay? Now, talking about blood transfusion, there are some things you also need to know. You need to know the PCV of the recipient, and that is what is going to guide you concerning the quantity of blood to give. So I can't really effectively talk about all that in like 1 minute, but this is what I can say.
No, we will bring you. We will bring you in next time, sometime. Don't worry.
Okay, thank you very much.
We have 2 topics now.
If you are in a place where blood transfusion is not possible, I will advise you to tell the client that where you are, blood transfusion is not possible. You may want to refer the dog to a place where it can be done. That's the only solution.
Yeah, Omobowale, thank you. Let me say something here. Ability to refer cases does not present any form of weakness. It shows maturity. When I was in practice, I referred a lot of cases as part, especially at Ahmadu Bello University. Close to me, that is the teaching hospital, veterinary teaching hospital. Let me say it again. Ability to refer cases in no way does not present any form of weakness. It's not a function of weakness. It's not tangential to weakness. It's tangential to maturity in practice, because we have our area of courage, whereby our area of competence and our area of capability. You talk about capability now, you're talking about tools, the diagnostic tools and equipment. If you don't have them, you don't have them. You have the competence, but you don't have the capability. You can expand your capability by referring cases to those who have, or towns or areas that have capability. And that's why people can take. I remember when we were in UNN, people had, we had one case of hookworm, ankylostomiasis, that was referred from Owerri. Then you see, we don't even have this on the Port Harcourt Express Road. They have to come all the way from Owerri, being referred to the practice and the veterinary teaching hospital, where we ran the screening and were able to know that it's the hookworm that was involved. And once we started the treatment and we refer back the dog back to the person who referred it to us to continue the treatment. So I think we should have areas where we can cohabit and interact our practices to make it to make it what it's called. Ukamaka, please. Are you a professor, please? Because there's some of us that are doctors. Are you a professor? Before
Good day, Prof. I'm an associate professor, sir.
Okay, you're on your way already. So, okay, the lady in South Africa.
Yes, sir.
Oh, okay. We'll put you on the hot seat. We'll put you on this spot on 28th to discuss rabies. Okay, Amaka, what do you want to say, sir, sister?
Okay, I want to say that since dog has 13 blood groups, most of the time, getting to know the particular blood group a dog has is a very big issue because you have to get the 13 antigens, and most of the time they don't come as a kit. So what we normally do in UNN is if that dog hasn't received any blood before, we do, you can give, after screening the blood and ensuring that the blood is wholesome for the dog to take, and doing all the things that Professor Omobowale has said in terms of preparation of blood transfusion, you can go ahead and transfuse because unlike humans, there are no antigen on the surface of their blood cells. It doesn't come out immediately. It just happens that they will develop the antibodies again. They don't have the antibodies ready against those antigens on their surface of red blood cells. So they develop it after 72 hours. So you can give the blood to the animal and ensure that you finish it within 72 hours, and you won't give it again unless you find out the blood group of that particular animal.
Okay, thank you.
Yeah, let me quickly add to that. Professor Ukamaka, said exactly what happens. In clinical practice, we don't type all the blood groups. It's not feasible, it's not financially possible, but we only type for DEA1, the DEA1 blood group. That's a big thing on its own. Yes, we know that there are no preformed allo antibodies against the sensitized, but another call for concern is this: some animal might have been sensitized before, and you wouldn't know. So if you do a blind transfusion using an animal that has been sensitized before, and use the blood of that animal and you transfuse it, for example, if the animal has been sensitized, let's say DA5 or 6 or 7, and you transfuse that blood to an animal that has it, even though it's a forced transfusion, because the animal that is the donor already has the antibodies against that blood group, there'll be reaction. So in addition to just transfusing blindly, we also advise that what's it called now? Both major and minor cross match be done so that as much as possible, there won't be transfusion reaction. So even though we say that first transfusion is safe, personally, I always advise my students, I always tell them, first transfusion is usually safe. Sometimes the source of the blood, the donor might have been sensitized and you wouldn't know. You do a first transfusion and within a few minutes, there is reaction. But basically, what Prof described, Professor Kamaka described, is what you do in a situation where you don't have anything at all. Thank you.
Yeah, thank you very much. That leads us to another topic, blood transfusion. They say we have today, I think we're having 3 topics already on the ground, and we'll come back as time goes on. I think we have a lot of lectures, at times outside the normal norm, and then at times expanding into the areas we've not even had before. We heard about blood transfusion when we were in the university studying, but the times phase will not allow us to go into deeper. But those who have gone into deeper in terms of practice and specialization, they need to learn more. So we have programmed our program here to enrich and to be an outreach, to reach out to almost all areas of veterinary practice, so that we can see how much we can see to expand our space. Dr. Abiade said something here that minocycline is in Nigeria, though it's I don't know, maybe you can talk about it. Minocycline, you know, Professor Omobowale mentioned about minocycline as one of the choice medications, and Dr. Abiade, sorry, quickly retorted that it's in Nigeria, but I don't know, but he said it's scarce. But he said it's in caplets.
He said it's scarce.
Yes, but he said it's in caplets. So maybe I unmute him to discuss, to throw more light on that. Professor Abiade, please throw more light on the presence of minocycline in Nigeria.
Hello. No, you know, when he said that he has never seen, I mean, minocycline is available, but very, very scarce. I mean, the last time I used it, I had to really request for some pharmacists to get it for me. So, and that's some time ago. I've not used it for some time, but I have seen it. I've used it. So that's what I went to, you know, to respond to him when he said anybody who has used it should respond to him. So I believe it should still be available, but I have not really looked out for it. Okay.
Yeah. But I think we have some good drugs. Though there are a lot of fake drugs in the human pharmacy. A lot.
There's a lot of fake drugs.
There's a lot of fake drugs. In fact, if it's not MediPlus, and they're all scattered in all the ShopRite complexes. It's a mega pharmacy. All the ShopRite complexes in Nigeria, they have this MediPlus pharmacy. If not, I'm not buying my medication anywhere, because the medication I see.
Are you advertising?
No, I'm not advertising. No, I'm not advertising. No. I'm only saying where you can get good drugs. You can get good drugs based on my experience. You can get good drugs anywhere. But the level of fake drugging in Nigeria is so high. So it's so high. And then another thing I want to say is this. For those of you who are looking for this lecture, it's permanent on YouTube. And I've mentioned our YouTube channel. And also, I'm going to send this YouTube video in all the platforms, so that people can expand it. But as you're expanding it, please advising the people, including yourself, to click on the subscription button, or subscribe button, and notification button, so that the algorithm of watching will be expanded. Then it gives us our content a high value. So that's the thing. I've sent the YouTube link, but even at that, once I send the video, you're watching the video, you're inside our YouTube link already. So I'll send the video around. You can watch it at any time. And when you go to our TV, Bluebird TV, you see a lot of videos that will enhance your practice, expand your practice. Next week, we are going to have heat stress. Another tire is coming. Another tire, is heat stress, and not in dogs or in poultry. And then we found out for the teachers here, another thing we found out, poultry medicine is a subset of it. I discussed this with Omobowale. Poultry medicine is a subset of avian medicine. And most of the teachings we are having in the universities and teaching hospitals are on poultry medicine in the name of avian medicine. Avian medicine is all embracing, multi-expansive, multi-elastic. The aviaries, I'm talking about companion aviaries, nobody is touching them, and they have quite a lot of diseases in that form. And then it's coming up in this country. People are keeping ornamental birds. And then when they have diseases, we don't know about it. But most of people and most of them, they go to pet clinics. So if you are studying pet medicine, and and another issue, if you are in pet medicine, it's not only dogs and cats are pets. Anything can be pet. You need to adapt yourself to the pet medicine in that environment. So if it's aviary, I've seen, I think in whose clinic, in Function's clinic, yes, in Lagos, in VI, I saw peacocks. They went and sprayed the environment, and many peacocks were down in that environment, and they brought it to that clinic. They didn't take it to a poultry physician, they take it to a pet physician. So being a pet physician, there's a lot of demand from you. Maybe that's one of the reasons why we're here, to be able to push. You know, when your thought had not gone to, your mind will never go there. But now we want to expand your thought and expand your mind. Now, I don't know whether we have any other. I say, sir, with due respect, I want to disagree that veterinary ethics is not well taught at undergraduate level. Oh, thank you. Maybe there is an update on that, because when we were 37 years ago, we didn't have much on veterinary ethics, but we still have to come back on it, so that maybe the younger ones will tell the older ones like us when it was not well taught. Oh, I'm so glad that Veronica Detunji is saying that it's well taught.
teaches the veterinary ethics.
Yeah, it's being taught, but it's not being deepened. That's what we are saying. That's what we are saying. And I don't know whether the topic raised this morning, which Abiade raised this morning, I don't know the practicality of it in what is being taught right now. So these are what we are saying. It's not about really now the ethics, but you see, there are some areas. You might read out ethics of veterinary practice all over the world, but don't deepen the one you are seeing in Lagos. So Adetunji, please, you can unmute yourself and enlighten us, because on this platform we're in an enlightening phase. So thank you, Veronica. Yes.
Yes, sir. Thank you, SARS, for this great opportunity. I want to really appreciate my teachers, our professors. You are all well appreciated, sir. So I just wanted to bring out is that it's not about like the ethics we were taught. The problem, because I could identify at undergraduate level, you don't really, some of them, because you have not experienced it, you don't internalize, you feel that, oh, can it happen? Like, what the concept they are discussing is that of second referral, second opinion and referral. In ethics, you will be taught that even you could refer for so many, it could be for treatment, it could just be for diagnosis. In that case, maybe you have a specialist who is specialized in that particular, who could give you a definite diagnosis. That we also think that you don't take over that treatment except there's an agreement that, okay, oh, you can take it over from here. So you just go there, the client comes to you, you make your diagnosis, you send back the client and they report back to the primary clinician, except it is referred to you for continuation, that you don't purposely take over treatment from another. That one is also unethical. You see, all those things are embedded in the know. But what I'm trying to say is that most time, students just listen to it and they even laugh off some of those things. It's only when they now get back to the field, because now the feedback we are having when they come back from master is that when you now mention, they say, and that time we're not even thinking about it. There's more understanding. So what I'm trying to say that maybe when we put more emphasis now on this topic, that when we were teaching them, because of this practical exposure here and there, they now know that, oh, this is what we are being taught now, is to prepare us. Because some of them even attempt to do surgery without consent, signing consent, from doing all sorts of things and shooting themselves in the leg when a legal issue arises from that case. That's what we are saying. They are trying, but even right now, the problem we're having with our undergraduate now is their attention is being divided by so many things distracting them. But it is also a feedback for me to also take back to the classroom now when we are teaching, so that we put more emphasis on this thing, that, see, this is what the reality outside there. It's not about you writing the note and putting it under your head. So it's about you knowing that these are the things you are supposed to know, you are supposed to do and not to do. And I think that is the essence of veterinary ethics and jurisprudence, knowing what guides the practice of the profession. You may know how to do it very well, but if you don't know the law that regulates what you should do and what you should not do, you could also so that's what I'm just trying to say.
Yeah.
Thank you very much.
Thank you very much. I mean, it's been insightful, very, very insightful. You know, in the undergraduate phase, people have a lot of things they want to do outside, and maybe the ethics might not catch up with them. Might not catch up. Like I am in the veterinary pharmaceuticals. There's ethics and rules guiding the veterinary pharmaceuticals, and you don't expect that same ethics to juxtapose it with somebody like Abiade in the pet practice, or Omobowale in the pet practice, or Ajayi in the poultry practice. Every side of practice has its own ethics. And I don't believe the university will cover all of them. But when you come out, as you're trying to narrow down your practice to area of your choice and competence, you'll be seeing some of these ethics unfold. What really we are bringing up is the ethics of pet practice. That's what we are going to discuss with Omobowale, Abiade, and Nasir. Because if you allow them to discuss ethics of the pharmacist angle of it, where I belong as a trader, it might be very difficult. So that's what we are saying. In the university, you generalize, but in the field, you compartmentalize. And that is what makes the difference.
Yes, yes.
Yeah, that's what makes the difference. Because it's in the university, actually, you are just going there to get the skeleton. But in the field, you start packing the flesh because the framework has been formed. And that's why people like me can come up and discuss scarcely or scantily in some areas of veterinary medicine. So that's the thing. I don't think we have any other thing. We've gone so far. Let me recognize, we have some, I don't know whether Dr. Laka is still here. Dr. Laka, I thank you. When I started my fellowship, you offered me, you were in charge of our accommodation in the postgraduate hall. You gave me a room in the postgraduate hall where I stayed for some time before I moved to the university, not the university accommodation, the university center. Thank you very much. I'm seeing you here again and again. I still, people who really helped me in life, I don't forget them that easily. And most especially when I needed them most. We have Tunji Nasir. He has spoken, former president of the Commonwealth, ex-this and ex-that of NVMA, secretary of InfoX, vice president X, ex-official X. I've been following him. Abiade is a mentor-in-chief. And please, I would like to partner with Abiade and most of you. Is this our course to mark out a track road for this our practice? Then my lecturer, Professor Vin Oshoinka, I don't know whether he's still here. He was here sometime. And then Olaleko, Professor Jeremiah Olaleko Taiwo, Dr. Felix Lawani was here, I believe. And then we have new upcoming ones coming up. And I think one day they will take over from us. And from what we have today, we have a far, far, far younger vet, Dr. Amaka Ozonna, moderating Professor Omobowale. That's the way we find ourselves, so that anything we can do to narrow gaps and narrow bridges and build bridges, bridges, or we're on top for it. So be it as it may, and I don't think there's any other question coming in. For those of you who are here, I've seen Dr. Nonso, and then the father was my lecturer. I've seen a lot of people here. Oh, I forgot to mention Dr. Fadipe. Oh, sorry, before I remove my name from the list. Registers in list of veterinarians in the country. Dr. is our acting registrar. Please, is here. Dr. Kemifuna all the way from Asaba. Enobong all the way from Uyo. Thank you everybody for being with us. Next week we are going to have heat stress. We have to have, it's an interactive program between our farmers, those who are in poultry farming, those who are veterinarians in poultry practice. Dr. has done a lot of work on that, and let's see where we are getting it wrong. And then somebody mentioned, hey, Omobowale said something about the tiki side. We lost that one along the road, but in the next 1 year, we are bringing a rural tiki side. I believe it be effective, and I believe it will be far cheaper than what you have in the field, so that many of your dog owners and pet owners can key in. It might even be some 50% or 30% less than what you have now in the field. In the next 2 years, we are bringing it. I won't disclose a lot of things. The registration is in progress. And once it's read out of the firm, Nigeria will surely have it. Unfortunately, it's our company, Bob Martin. It's Bob Martin that is having that patency when the new one comes. And so that's it. In the next 2 years, maybe this is an advertising spot for 2 years to come, so that every pet owner will have an oral ticicide. I promise you that. At this my age, I'm not looking for bogosity. I'm looking for things that can be catchy, that the catchment area can be broadened. It will not be elite. It will be elitist. It will not be elitist to say. It will cost across the strata of the society, the economic strata of the society, especially those who love dogs. Thank you very much. And then next week, by this time next week, we are coming up with a very hot topic. And even the topic we are going, I've seen Ukamaka. She's going to handle rabies on the World Rabies Day, 28th of this month. His name has been penciled. And then the upper week, we are bringing in Julius Aruna to come and tell us opportunities of veterinary medicine in Canada. Professor Mipe has taught us and has lectured us and spoke sprightly on opportunity of veterinary medicine. It's in the YouTube, opportunities of veterinary medicine in West Africa corridor. We are coming up. We have a lot of topics. The Kenyans are ready to come up and give us lecture, but let us be taking it one after the other. On this premise and on this note, thank you everybody for being with us at this time.